We are delighted to have Professor Claus Wendt, Professor of Sociology of Health and Healthcare Systems from the University of Siegen in Germany. Please enter the stage.
First of all, I would like to take over my best regards from Heidelberg, from where I arrived yesterday. And I also would like to thank the organizers of this conference for inviting me to this amazing conference. And I think that the question of this conference, how can good quality healthcare and equal access to medical care achieved and guaranteed in an aging society will be of utmost importance for our societies in the future. And in my presentation, I will focus on comparative health policy. I will focus on findings from comparative research and provide examples how other countries started to develop health policy solutions that are related for achieving our goal of providing the basis for healthy aging. And I will start my presentation with an overview of health policy in international comparison and focus on similarities and differences among different European countries. And second, I will provide information on access to medical care, and I will focus on gatekeeping on the one hand compared to free choice of doctors on the other hand, and will focus on the consequences that are related to these two different types of access regulation. And this part, there the data stem from the Survey of Health, Aging and Retirement share, and therefore the focus is primarily on older people in Europe. And my third topic are cost barriers, such as private co-payments, and is related to the question how these kind of cost barriers or experience with cost sharing has an influence on the confidence of receiving quality health care when being seriously ill. And as a final point, I will try to share with you some information, first information on a new research project where we concentrate on healthcare seeking of older people in Germany, and in particular on the role of social networks, of self-care, and also on health literacy for receiving good quality care and making a decision if you have any kind of condition. Well, but let me start with the main focus of my research over the last few years. I've been focusing on health policy in a comparative perspective, and my starting point was that the well-known types of welfare states you're certainly familiar with are not sufficient when you focus on healthcare, because healthcare is much more specific than general welfare state types, and the idea is that you can analyze access to healthcare, health inequalities, and also prevention in a much better way if you focus on different types of healthcare systems and not on more general welfare regime types. And I just want to share with you here very brief ideas. Some of the findings are summarized here in this table, and we identified 3 different types of healthcare systems. And here you can see in the first line there are countries like Austria, Belgium, Germany, France, and Luxembourg grouped in this type of healthcare system. And this type of healthcare system is characterized by a very high share of total health expenditure, a high share of public funding, and moderate private out-of-pocket payments. One of the most important characteristics of this type is a very high level of service provision, in particular in the outpatient sector. Another interesting characteristic of this type of healthcare system is low regulation for patients with regard to access to medical care providers. So most of them have free choice of doctors and direct access to both general practitioners and specialists. And medical doctors are remunerated mainly on a fee for service basis. So the income chances, in particular of self-employed doctors, are rather high in these type of healthcare systems. And the second type of healthcare systems consists of countries like Denmark, Britain, Ireland, Italy, and Sweden. And in this type of system, the level of total health expenditure is lower. They also have a high share of public funding and moderate out-of-pocket payment. And the main difference compared to the first type is that service provision, so the level of service provision, is lower, and in particular in the outpatient healthcare sector. Another important difference is that access to medical doctors is much more regulated, so most of the countries have any kind of gatekeeping systems, and they are financed mainly on a capitation basis, so the control of income chances of medical doctors is much stronger than in the first type of healthcare system. And I will refer to two of the main differences between these two types of systems, to outpatient healthcare on the one side and to the question of access regulation in other parts, and I will present some of my findings from comparative research. When it comes to these two types of system, another interesting issue is that in all countries, in the outpatient healthcare sector, new organizational forms have been invented. So most countries focus now not only on the single-handed practice, but they develop larger units of service delivery, so healthcare centers. In Britain, primary care centers, or in Germany, health care centers, which is called in German medizinische Versorgungszentren. And in all kinds of units, the main idea is to provide better access to outpatient healthcare, and in particular for patients with multiple chronic conditions, because in these larger units of service delivery, there is stronger collaboration among different healthcare providers, and they can serve the needs of older people much better than it has been used in a single-handed practice that still exists in a large number in European countries. I will now come to my second topic, to the question of access regulation for patients when trying to use healthcare services. And I will contrast healthcare systems with gatekeeping on the one hand and free choice of doctors on the other, but we did not, in this comparative research, only focus whether there's gatekeeping or not, but we developed an index of access regulation so we can compare countries with different degrees of regulating patients' access to healthcare services. And we concentrated on the level, but also on inequality of healthcare utilization in different countries. And one of the first findings we had is that in countries with low regulation, so with free choice of doctors, here on this axis you see the number of chronic conditions, and on this axis you see the probability of receiving medical care in different countries, and also in Germany and in France, also in Belgium or in Austria, where there's low access regulation, already very healthy people have a high probability of visiting a doctor, and there's not a very steep increase of doctor visits in these countries. And on the other hand, in countries like Denmark or the Netherlands, where there's much higher degree of access regulation, Sweden would also be part of this group of countries, when you just control the patients with no chronic conditions, there is a much, much lower take-up rate of medical services, and only when there is poorer health, then healthcare utilization is getting much, much higher in these countries. And one of the consequences, or what you may learn from these different experiences in different types of healthcare systems, is that we may, if we want to control healthcare services and focus in particular or concentrate healthcare services on those parts of the population which are really sick, in my view, private cost sharing is not the right instrument, but maybe regulation of patients' access is a better instrument for achieving this goal. And the second finding concerns the level of inequality. And here we compared countries with different levels of access regulation. So on the right hand, there's strict regulation. On the left-hand side, there is free choice of doctors. And we compared or analyzed inequalities among educational groups. And what you can see here is that in countries with free choice of doctors, in France, in Germany, in Belgium, for instance, there's a quite high inequality when visiting a specialist doctor. Even when you control for health, for educational, for income, for all other influence factors, there's much higher take-up rate of specialist healthcare in these countries, while in countries with strict access regulation in Denmark and the Netherlands, on the other hand, on the right-hand side, there's hardly any inequality among educational groups. Sweden is somewhere in between with somewhat stricter access regulation compared to Denmark, but also with higher inequality. And so the question is what you can learn from this finding. One possibility is that you have to have more regulation for patients when accessing medical doctors. But on the other hand, you have to take into account that you need to get patients involved. And so the question is what you can learn from a policy perspective from these findings. And in my view, you also have to keep into in your mind the concept of exit and voice. And here on the left-hand side, this is the exit concept. So if you are not satisfied with your doctor, you just change to another one. And this is not really good for developing a long-term and trustful patient relationship. On the other hand, you are forced to get involved with your doctor. So this is the voice concept. And in my view, this is in particular better in developing a trustful doctor-patient relationship in these countries. And so the summary of these studies is that patients with higher education have easier access to specialist healthcare when you control for all other factors, including the health status. And this relationship is particularly strong in systems where people have freedom of choice and direct access to specialist healthcare. I now come to another topic, to the question of cost barriers, such as private co-payment. And we have asked in these comparative studies how cost barriers affect the confidence of receiving good quality, safe and quality medical care when becoming seriously ill. And our first result in these comparative studies was that in the United States, 1 out of 4 patients, and in Germany, 1 out of 8 patients have made the experience of not going to a doctor because of costs, despite having a medical condition. While other countries, such as the Netherlands and the UK, with a strong focus on equality, patients hardly have made these experiences. For the Netherlands, we have to take into our mind that these data are from 2006, exactly when the new system has been implemented. Now it has been much more privatized, and we have to look at the data whether they are still able to have this very positive result that people don't really have made the experiences of not going to a doctor because of costs. And based on these findings, we have analyzed, or we wanted to know, which social groups have in particular made the experience of cost barriers. And we already have some effect, in particular in the United States, of gender differences, of education, of income, and of health status. But the main impact on the experience of cost barriers is the insurance status. So in countries like New Zealand, Australia, Germany, those which are only in public plans have made much more often the experience of cost barriers than those with additional private insurance. And you can see in the most private system, so to say, in the United States, there are huge differences among social groups. And interestingly, although from the system perspective, Medicaid patients, so the lowest income groups in the United States who qualify for Medicaid, should have the least barriers when entering the healthcare system, but in practice you see they do. So they much more often have the experience of cost barriers, although they are in need of medical care than, for instance, Medicare patients. And the second question we have analyzed was how these negative experiences with the healthcare system affect the level of trust or confidence in the healthcare system. And again, we see that there is an effect of gender differences, of education, income, and in particular of the health status. But the strongest effect on a loss of trust, of confidence in the healthcare system is the experience of cost barriers. And the interesting thing, in my view, is that you have this experience of cost barriers even if you have a minor illness. So if you are in need of pharmaceuticals but have no money to pay for it, then you don't take up these pharmaceuticals. And in the long run, these smaller negative experiences have a very strong effect on the confidence of receiving the necessary health care in the future when in need of medical care. And this is, in my view, what we really have to take into account when we implement and increase private co-payments. Because this may have, in the long run, an important negative effect on the confidence in the system. And in my view, it is quite important that people have the security that we all will receive, when really in need, the necessary health care. And in my view, it, in the words of Shmuel Eisenstadt, it represents a marker of certainty that we will receive necessary health care when being really in need. In a related study, comparison of 15 European healthcare systems, we concentrated on factors that influence the satisfaction with the healthcare system. And I just want to come to two aspects. on some institutional factors, and in this EU comparison, we found, for instance, that the level of general practitioners and also the level of healthcare providers in outpatient healthcare has a very strong effect on patients' satisfaction. Not the level of inpatient healthcare, but the level of outpatient healthcare. And interestingly, the level of access regulation, so whether you have free choice of doctors or not, has not a very strong effect, or here we have no effect at all on patients' satisfaction. So this is important for countries like Germany, Austria or Belgium, where in the political debate, the free choice of doctors is evaluated very highly. But you can see for patients, it really matters that they have access to outpatient healthcare, so there where the patients live, but not whether they have all the time free choice or not. I now come to my final point, just to introduce you to some first ideas of a new research project we are doing. So this is about the project Healthcare Seeking by Older People in Germany. And we, in particular, want to focus there on the social and institutional context of decision-making in the case of sickness. And our starting point was that in earlier research, the main focus on healthcare utilization was what has been happening over the last 6 or 12 months. And in particular, when we focus on older people, and you ask older people, they don't really know what they have been doing half a year ago. So in our project, we start to focus on decision-making in case of acute illness symptoms. So what really happened in the last 2 years before we do the interview? And then we will do a follow-up interview 4 weeks ago. So we have just a period of 6 weeks where we will ask exactly what has happened, what kind of symptoms did the people have, and what kind of decision did they make when they experienced the symptoms. And in my view, this is quite important because very often, about only in 50% of cases, when people have any kind of medical condition, they enter the healthcare system. And because the role of doctors will change in the future, they have to be much more involved in informing patients what to do, what kind of preventive healthcare strategies to implement. They need to know much more what happened in the time before they enter the healthcare system, and this is what we try to find out. And we particularly focus on alternative healthcare strategies, on self-care, also on the question of health literacy, and we will focus on the role of social networks and also on the role of the healthcare system. And this is becoming, even on a national level, much more important because related to demographic changes, the inequality on the regional level will increase. In Germany, we now already have the experience that there is a much lower degree of medical doctors in rural areas in Eastern Germany, and this inequality on the regional level will grow, so we will concentrate on the question how the institutional structure on the regional level will affect the decision-making in the case of healthcare. But this is only something I will be able to provide first results in about half a year, and I would be happy to come back. And I really would like to thank you for listening to my presentation. Thank you very much.
Thank you. Thank you, Claus. It's interesting that you also touch upon these facts. If you're safe, if you can have confidence, if you can security, which is, of course, creating many diseases with fear. And I would just like to have one interaction part now with the audience as we did yesterday, because a focus, a wish from decision makers is very often that the patients are, the older people are as autonomous as possible. And we will see what the audience, if we can please have that question, Frippe, if you please grab your Mentimeters. What enables autonomous aging, would you say, if you would pick one of these 5, what would be the most important thing? To harness advanced technology for individual use, the effective collaboration across health and social interface, proper incentives for entrepreneurs to develop new mechanisms and strategies, support from family and community groups, including then the civil society, or designing new sheltered housing in a neighborhood close to the elderly's children. I just learned at the mid-dinner yesterday that we're not supposed to say the elderly, but old people, according to new standards, but didn't know that when I wrote this. So what out of these, even if they would all be important, would you pick as the most important one? Which one would you pick, Richard? Or we start with Claus. Yeah, I saw that in your eyes. Yeah. Which one would you think would be crucial?
Well, this is really difficult to answer because, well, it really depends on your perspective.
Yes.
In my view, all are really important, and for instance, the support from family and community is a very, very important issue. But if you leave it like this, according to what we have found in our comparative studies, it will immediately increase inequality because some families are better able to do it and some communities, richer communities, are better able to solve these questions. So we certainly have to combine these ideas with number 2, so effective, very strong collaboration between different healthcare and social care providers. And I think this is a strength of the Scandinavian countries, that there's much closer collaboration between healthcare and social care, and we have to take more advantages of this situation. In Germany, for instance, there's a very strict separation between all sectors, and in particular between healthcare and social care. So we will gain certainly more from question 2, and because you have in part at least solve this question, maybe here in Scandinavia, in Sweden, you can also concentrate on other aspects. But without strong collaboration, I think
it won't.
It won't work.
Well, we're going to reveal what the audience more than half. Yeah, of course. And you know, we have had our trust in the state a lot, and maybe we understood from the Queen not the least how important it is that a family has the resources around and the mental and emotional capacity to help. So, Richard, what are your associations to what you heard also Professor Claus say?
Well, it's first of all, thank you very much. Very interesting presentation, as always, Claus. In terms of the issues that you raise, as you're well aware, a number of these questions about whether there should be a stronger state or whether there should be diversity of various ways of funding and delivering care, this is not the first time they've been discussed. They have a long history, as you're well aware. But you said something that I found very important early on. And I think it was your first study, that stronger regulation in your mind is a positive direction for health systems in terms of achieving more equity. That seemed to be what you were saying. And the question that I had, thinking about yesterday and what was said yesterday, is how do you balance stronger state regulation, more public control on the one hand, with the elderly having the ability to have more self-determination, self-control, and ability to steer what happens to them? Isn't that a contradiction?
In part it is, and so in the end it's a political decision where this whole society should be involved. So it's not a more or less academic perspective. But in my view, one possible solution is to go in the direction of larger units of service delivery, where patients will receive, or older people, much more information from experienced experts, and that the way these healthcare centers are built up is more or less regulated, or there are incentives to establish these centers also in rural areas. Otherwise, they wouldn't do it. If you just leave it to the medical doctors, to the healthcare providers, they would go where they can earn their income. And so for this part, to have centers provided all over the country, you need regulation, but then you can get patients and older people more involved if you have good quality healthcare centers that provide information on prevention, on healthy lifestyles, and all other aspects in one unit of service delivery. So what you know from Britain...
So the minute you move from a fixed system with standard level of services regulated by government, then in your estimation it becomes less effective in terms of providing the elderly with the services they need.
Well, my main argument is when there is no kind of regulation, then certain regions will not be provided with these services.
Well, of course, there's a difference between strong regulation and no regulation. There's a whole intermediate territory. I guess that's the kind of question that I think perhaps is most interesting, is at what level and what type of regulation. How do you get smart regulation?
Yeah, I hope we will. You have, of course, the answer.
Smart and lean regulation,
Sorry, yes?
Yeah, certainly one idea is to get the actors involved. And again, I think these larger units of service delivery are key because they have the capacities to collaborate with people from social care, with people from the political field, and with patients' organizations. If in a system, and this is, well, I have a more German or continental European perspective, and we still have mainly single-handed practices in the outpatient healthcare
which is
system.
why you find it, the grass is greener on the other, in the northern part of
absolutely.
Europe.
It is. Well, there's more rain, so it's greener.
But I think we will enjoy discussing this, because I think probably the solutions are here if we just put our minds together and identify where we want to go and how we want to benefit from all these insights. So we would like to thank you very much for presenting. Thank you, Claus.